Good morning, judges. The first study that I'm presenting is a randomized phase 3 study where addition of cannabinoid to palinocetrone, dexamethasone, and apreptin, that is a 5-HT3 antagonist, dexamethasone steroid, and NK receptor agonist versus the standard of care, that is palinocetrone, dexamethasone, and apreptin, is being compared to prevent CINV in highly emetogenic chemotherapy. So we all know that chemotherapy-induced nausea, vomiting is an unpleasant and worrisome side effect for majority of the cancer patients undergoing emetogenic chemotherapy. And highly emetogenic chemotherapy regimens have incidence of CINV more than 90% without appropriate anti-emetic regimens. So the aim of prophylaxis and treatment in these patients should be to completely control the CINV. That is, the complete response should be there. According to the palinocetrone are the appropriate antiemetic drugs to be used in. Despite these regimens, the complete response rates are around 70 to 80. So with this background, cannabinoids, an extract of cannabis sativa containing two major molecules, that is delta 9 tetrahydrocannabinol and cannabidiol, in a 1:1 ratio has been shown in the form of buccal spray to reduce CINV. So in this study, we are evaluating a single oral capsule containing 1:1 ratio of both compounds, 2.5 mg each. And the aim is to see whether this combination to the standard regimen helps in improving the CR rates. So this is the study design, where on the control side, the standard regimen is being given, whereas on the experimental arm, the cannabinoid capsules are given 3 times a day at 4 to 6 hourly intervals, starting 1 day prior to the chemotherapy, on the day of chemotherapy, until day 4 post chemotherapy. That is -1, 1, 2, 3, and 4. So the primary objective is to see and compare the complete response rates. Complete response rates is defined as the proportion of subjects with no vomiting, no significant nausea, and we will measure nausea on a visual analog scale. And there is no use of rescue medications during this pre-specified highly emetogenic chemotherapy protocols for 1 cycle of chemotherapy. Secondary objectives are to see whether the MSS rates, compare the significant nausea, quality of life, and the tolerance and side effects of this regimen. So the main chemotherapy regimens that are the highly emetogenic chemotherapy that are being included in the study as any cisplatin containing regimens, epirubicin cyclophosphamide, adrimacin cyclophosphamide used in breast cancer, and carboplatin containing regimens with an AUC of more than 4. So this is the standard inclusion criteria. As mentioned in the prior slide, the highly emetogenic chemotherapy protocols being given to more than 18 years of age of either sex, and the patient should have been chemotherapy naive with an ECOG performance status of less than 1. Exclusion criteria would be pregnant patients, the patients who have experienced MSS or clinically significant nausea in the 24 hours preceding to the first dose of the regimen, any patient with an active peptic ulcer disease or intestinal obstructions or raised ICT, which would be leading to vomiting. So the efficacy measurements will be done by giving the patient diary, a telephonic evaluation by the study nurse. Nausea scale, visual analog scale would be used to measure the nausea, and quality of life measurement by FLI questionnaire. So it's a parallel randomized open label phase 3 study where 644 patients will be enrolled into the study, 322 patients in either arm. The assumptions are that 70% of the patients in the control arm will have complete response rates. And by adding cannabinoid, we are trying to improve the complete response rates by 10% to 80%, two-sided alpha of 5% with a power of 90%, and assuming 10% attrition rates. The accrual is supposed to be 1:1 randomization over a period of 2 years, followed by 6 months for follow-up. Thank you. This is the first study. So this second study is an open label prospective 3-arm study where we are evaluating the efficacy and tolerability of oral disintegrating strips of vitamin B12 versus oral tablets of vitamin B12 and intravenous administration of vitamin B12 in Indian patients post-gastrectomy. So the background is that vitamin B12 deficiency is quite common in post-gastrectomy patients, and traditionally parenteral vitamin B12 in the form of IM or IV injections have been given to patients post-gastrectomy to prevent the vitamin B12 deficiency-induced anemia. Oral B12 administration has shown similar increases in the B12 levels and the homocysteine levels in the blood. And there are right now sublingual disintegrating strips of vitamin B12 available too, which offer the potential for better compliance, avoids hospital visits, and better bioavailability of the drug. There is, however, no data on the oral vitamin B12 supplementation and the efficacy in reducing the anemia in these patients. So with this background, we are proposing to evaluate the efficacy and tolerability of oral disintegrating strips of vitamin B12, IV vitamin B12, and oral vitamin B12. Three arms where oral formulations are given in two arms and IV is given in one arm in Indian patients post-gastrectomy. So the primary objective is to evaluate the best route of B12 administration that would prevent a drop in hemoglobin by 2 gram per deciliter or more from the baseline in post-gastrectomy patients over a period of 4 years. The secondary objective is a quality of life assessment, the complete hemogram changes in hemoglobin MCV, ANC, and platelet count, the changes in other parameters like iron studies, and also the percentage of patients developing adverse events. So the inclusion criteria is that adult patients more than 18 years with a baseline hemoglobin that is not anemic and who has undergone a total gastrectomy or subtotal gastrectomy for gastric cancer patients. The exclusion criteria will be patients where the hemoglobin level is less than 11 and less than 10 for males and females respectively, hypersensitive to the formulation, pregnant lactating women, and patients with any kinds of oral supplementation, multivitamins that has been received within 4 weeks before the randomization after surgery. So it's a randomized 3-arm open label study where we are not comparing the arms amongst each other. We are just giving in arm 1, the patients are receiving the oral disintegrating strips of vitamin B12 at 1,500 microgram per day for 4 years. In arm 2, patients are receiving IV vitamin B12, which is a standard, given daily for 7 days, followed by weekly for 4 weeks, and then once a month for 4 years. Then in arm 3, the patients are receiving oral tablets of vitamin B12, 1,500 microgram per day. So the statistics is that we would be accruing 180 patients, that is 60 patients in each arm, over a period of 2 years, followed by 4. As assumption, anemia is seen around 80% of the patients, and we would want that this number of patients should increase to 50%, that is an increase by 20%. The arm that would prevent the development of anemia in less than 50% of the patients would be considered as a winner. The compliance assessment to the therapy would be by a trained researcher who would telephonically contact the patients for assurance of compliance. We will provide the diary cards so that they would keep a track of the doses on drug compliance. And also when they visit every 3 months to 6 months for the follow-up, we would collect the empty wrappers and boxes and vials of the medications that has been dispensed. Thank you.